to the July 13th, 2020 COVID-19 clinical care rounds focused on EMS patient care and operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 EMS challenges and successes. If I'm preparing my EMS system for COVID-19 patients, the clinicians I want to learn from are from those who have the most experience. This is a voluntary public-private collaboration. Thank you to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, July 14th, will be critical care rounds. Thursday, July 16th, will be emergency department rounds. It is self-evident that our nation's medical response challenges are changing every day. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. At times we have other disciplines, such as respiratory therapists, school nurses, veterinarians, and dentists. Our appreciation is extended to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. We continue to receive questions for each of these rounds and apologize in advance that we're not able to answer all of them. We do select major themes from questions received and hope to cover some of those. We'll also be doing crowdsourced and polling questions with results shown in real time, so we all have the opportunity to learn together. I'll now turn this over to Dr. Bruce Struminger for logistics.
Thank you, Rick, and thank you to our colleagues in Phoenix and Houston who will be presenting today, as well as our expert panelists joining, and particularly to the over 270 participants joining today. So just a few logistic issues as we get going here. Hopefully everyone will see at the bottom of their Zoom toolbar a Q&A function. We really appreciate your questions and comments, so put them in the Q&A space. We'll be monitoring that, and our expert panelists will also be monitoring that. In the chat function, please put any technical or logistic questions, and Rick will be asking a crowdsourcing question in a few minutes. That'll be an open-ended question, and the chat function is the best place to put your answer to that. Again, we really appreciate your input. We are recording the session, and your attendance is consent to be recorded. Thank you for that. The presentations for today's session are linked to the most recent email announcement and will be on our website with a link to the recording link in the next day or two. And we'll be sharing that link in the chat, and it's available on the announcement. CME will also be available from the University of New Mexico, where Project ECHO is based. There should be a link in today's email announcement to the survey and to the instant CME, and we will put a link in the chat about 15 minutes before the end of the session. We really appreciate your feedback when you complete the survey. It's how we know what your priorities are and how you feel we're doing, and it helps guide us in the next sessions. A little bit about data use. we're collecting information through the registration, through the Q&A, through your chat comments, the poll responses, et cetera. And that information is shared with the Department of Health and Human Services. All your individual data is kept confidential. And these data, though, are used in a variety of reports and communications. And Rick will say a little more about how that's used at HHS to inform policy and decisions about the response to the COVID-19 pandemic. So with that, I want to hand the microphone over to Sharon Van Arsdale at Emory with NETEC. Sharon.
Thank you so much, Bruce. Appreciate it. Good morning, good afternoon, happy Monday, everybody. My name is Sharon Van Arsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. By background, I'm an ED nurse. I'm also the Director of Education for the National Emerging Special Pathogen Training and Education Center. And it's been an honor and a privilege to be able to represent NETEC and partner with Project ECHO. As you heard Dr. Hunt say, it's allowed us to really better understand what some needs are out there, allows us to do deep dives into topics that do come up on these clinical rounds. So we do have several webinars planned for July and into August, and many of them are two-part series. So we have a two-part series on long-term care, a two-part series on surgical care and considerations. And we also do have a webinar coming up on dental care. And then into August, we have a two-part series coming up on supplies and shortages and some strategies around that. So please check us out at netec.org. Thanks, Bruce.
Thank you, Sharon. And I didn't see Rosha McCoy with AAMC, but the AAMC is a partner of this initiative. And we just want to remind all the participants about their clinical guidance repository. It's really a treasure trove of resources, clinical resources that they are constantly updating. And we would encourage everyone to go to the website. The URL is at the top of the screen here, and review and take advantage of those resources. With that, Rick, I'm gonna hand it back to you for the crowdsourcing question.
Thanks, Bruce. The crowdsourcing question for today is pretty simple and straightforward. As an EMS clinician, what is the biggest challenge you are facing today in responding to COVID-19? As an EMS clinician, what is the biggest challenge you are facing today in responding to COVID-19? When you respond, it would really be helpful to indicate the country or area of the United States you're responding from, so everyone has an awareness about what's going on where. Would be really helpful. And for those of you who participated before, you know that the more people who respond, the more we have the opportunity to learn from each other. I'm now going to ask each of the panelists to please unmute themselves, and we'll go around and do quick introductions of our panelists with your name, title, and affiliation. Dr. Kramer, please.
Good afternoon. I'm John Kramer. I'm an emergency and EMS physician, currently the director of the National Office of EMS at the National Highway Traffic Safety Administration. I'm also the team lead for the EMS pre-hospital team as part of the HHS Healthcare Resiliency Working Group, and an EMS medical director for Caroline County, Maryland, Department of Emergency Services.
Thanks, John. Dr. Kupas.
Hi, Doug Kupas. I'm an emergency and EMS physician in Central Pennsylvania with Geisinger Health System. I'm also on as a member of the NAMSP board.
Thank you. David.
Hi, I'm David Tan. I'm an emergency physician and chief of EMS at Washington University in St. Louis, and the president of the National Association of EMS Physicians.
Thank you. Phoenix Fire and EMS, welcome. And if you could just your name, we know where you're from, but your names be great and your titles.
I'm Captain Joaquin Torres. This is Roy Rogers, and then we are right now Tina Rubio, we're part of Phoenix Fire Training, and Roy Rogers is the vaccine program manager.
Thank you. Rob?
Hi, I'm Rob McClintock. I'm Deputy Director of Fire and EMS Operations with the International Association of Firefighters.
Thank you. Dan, Gerard, if the internet connection is working, we'll see.
I'll give it a try. Dan Gerard, registered nurse and paramedic. I'm the EMS coordinator for the City of Alameda Fire Department, and I'm the vice president of the International Association of EMS Chiefs.
Great. And Garth, welcome back from last week. You presented last week. Great to have you back as a panelist.
Well, thank you. My name's Garth Gamer, I'm Medical Director of Phoenix Fire, Glendale Fire, and Surprise Fire in Maricopa County area, and glad to be with you again.
Thank you. And hang on for a second. Kevin Schultz, please.
My video is not working. That's okay. My name is Kevin Schultz. I'm Assistant Medical Director at Houston Fire Department and Assistant Professor of Emergency Medicine and EMS Fellowship Director at McGovern Medical School in Houston.
Thanks, Kevin, for joining us again. Kevin co-presented along with Garth last week. We had Phoenix and Houston last week. They're medical directors, and it's great to have you both back. And let's see, Dave Gerstner.
David Gerstner with Dayton Fire Department, and I'm the regional MMRS coordinator for 10 counties of West Central Ohio.
Thanks very much, Dave. So it's actually, I'm really excited about this particular rounds in that we've had medical oversight, medical direction, leadership from many EMS systems over the past rounds. And it was long overdue, at least in my view, to have people who are actually taking care of patients in streets and homes and places of work present to us. And so with that in mind, with the assistance of Garth, Kevin, and others, we've been able to have both Captain Crowley, Captain Isabel Sky Eagle, and Captain Soto present to us today from Phoenix and Houston, respectively. The way we're gonna run this one is Captain Crowley from Phoenix is gonna go first. We will be pushing the slides from Echo, and Scott, if you just say next, that'll work just fine. And the same for Captain Isabel Sky Eagle and Captain Soto as well. We'll push the slides from our end. If you could just say next, and that should work just fine. So we'll start with Captain Scott Crowley from Phoenix Fire Department. Welcome, and thank you.
Awesome, thank you. Thank you for the opportunity to present today. My name is Scott Crowley. I work at Fire Station 25. Recently, we've had a huge influx in Maricopa County, City of Phoenix, and Station 25 and for COVID calls. I know in the first couple weeks, or actually month, we saw minimal COVID experiences or COVID patients other than at care facilities, but we've had a huge uptake recently. I wanted to briefly discuss what our 911 system looks like. I work on a fire truck, which you can see on the screen there, Engine 25. We have 3 shifts. I work a 24 on, 48 off schedule. We also have our own ambulance or transportation system. At my fire station, we have 2 fire trucks that run and 1 ambulance. We've been averaging at least 5 to 6 COVID calls a shift per truck as we've been moving through. And recently, about maybe 3 weeks ago, we had a huge uptake, which I was talking, we had 17 dispatches, COVID positive dispatches in 1 shift. And so it's been extremely taxing on our system. I can't say enough about the leadership of Phoenix Fire and Dr. Gamer's leadership as well, as far as pushing out early protocols to us, not only for PPE, to be inclusive of masks, gloves, goggles. As everyone knows, there was a shortage. Some of our staff at EMS actually looked into getting us rain ponchos. While that might make some of you giggle, they actually worked quite effectively. They were clear. Gave us an opportunity to try to further protect our members and also provide some coverage for the patient as we transported them in and out of the ambulances and into the hospitals, so they did not expose or further expose any of our staff. As we've seen these uptick of calls, if you'll go to the next slide, please. these were the protocols that Dr. Gamer and the state medical directors had come up with. You can see the adult treatment guideline on the right-hand side, and then you can see a further guiding document on the left-hand side there. I've included these and we can share these, and I'm sure Dr. Gamer would be willing to share these documents as well. You can see that they were dated on the left-hand side of your screen there, March 10th. So these protocols came out early for us and gave us the right direction on how to encounter COVID patients and interact basically from a wide spectrum of signs and symptoms on the calls that we were going on, everything from flu-like symptoms to fevers or other calls. Again, most of the calls we saw in the early stages were at care facilities. We have a large number of care facilities in Phoenix, a huge retirement population. And so we have inter-facility ambulances that transport mostly for those facilities, but we do have some 911 response there. So if we would see patients with low O2 sats or alter level or high fevers that were unable to, maintain their airway or their respiratory drive, we would be called as a 911 system. We also came up with some different or changed some of our equipment. So we were using simple masks with ports on the side. We went to a traditional non-rebreather mask. We moved away from the LMA and went to iGels for passive oxygenation with the purpose of just hooking up the oxygen. And we also would cover the patient in a code protocol with another mask to minimize the atomization of the COVID virus. We reduced the number of CPAP and BiPAP treatment. As we would approach the hospitals worked closely with Dr. Gamer and EMS. We would stop all resuscitative efforts as we moved them into the transition and got them into the room, which would include SVNs, bag valve mask, or CPAP or BiPAP as we move them into the hospitals. So if you'll go to the next slide, please. This slide was updated as of yesterday. The numbers came out this morning and they're a little bit different, but you can see number of cases for 122,000. And you can see where Maricopa County is highlighted in the red there where I work, or where we work here in Phoenix. We dispatch for 27 cities in our 911 system. We have an automatic aid system. And so we run into other cities. I typically run into Glendale, the city of Glendale. Hence, Glendale would run into us just depending on where the trucks were located and where the 911 calls were generating from. Next slide, please. So this is really the critical slide that I'd like you to look at. That box represents basically a little under 6 square miles. And that first due, or my first due, 85033 zip code is the busiest zip code in the state of Arizona right now. I think at one time we were told we were 3rd in the country. So it's pretty significant. You can look at the scale on the left-hand side. It's all connected by red. So if I was to be able to move that box around, which is a link off our Arizona DHS website, you can see that the surrounding zip codes to my first due area also have around 2,000 calls. If you read the slide on the left-hand side, you can see what the population or density population is over there, which is pretty significant. As we go on these COVID calls, Dr. Gamer and our leadership through the IMT, specifically our operations boss, they put in a system where we could tag COVID patients. So if we went on somebody that was displaying a fever or a cough or signs and symptoms related to COVID, had not been tested, but we were suspecting of it, we were able to tag that call, that address, and that patient in our computer-aided dispatch system, and they would flag it and then push it over to our infectious control officer. That gave us a huge resource to be able to try to track these patients, because I'm not sure if anybody else has experienced this, but once we take a patient to the hospital, and whether they're known COVID positive or not, the hospital would test them. It would take 5 to 7 days to get the results back for the hospital. Through the communication system of the hospital, it would take another 5 to 7 days to get back into the field. You can imagine if we're working a 24 on, 48 off shift, how many additional people we come in contact with after that initial exposure. So contact tracing for us is very challenging and very difficult to move through our automatic aid system or our 911 system. As we receive notification from our infectious control officer, emails and communication were sent out to the crews that were in contact. If we had a member test positive, our infectious control officer let me know that we've had 72 confirmed firefighters for the city of Phoenix that have tested positive. We've had many more that have taken the leave, the CARES Act leave, and self-isolated because they had an exposure, which creates staffing issues for the fire department. Most likely, we're going to continue that as we continue this spike, but hopefully sometime soon we'll be leveling off and continue to use our PPE to protect our members. Most recently, our operations chief and our medical director, working through with labor, has come out, and we're not only doing social distancing in the stations, but we're also wearing masks in the stations and maintaining a cleaner atmosphere or social distancing atmosphere. You know, it's very hard to do that in a fire truck, but we're still wearing our masks, and even around the kitchen table. Again, I work in a multi-company station, so we typically have about 12 people at the dinner table, and it's really hard to eat chow with a mask on, but we try to practice social distancing and accomplish that as the best we can. You go to the next slide, please. So here's an example of a decon team. Decon 2 is what we call it here at Phoenix Fire. So anytime we have a COVID positive patient or we tag a COVID call, the alarm room is notified through our battalion, or the crew contacts the battalion chief contacts the alarm room sends out decon 2 to our station. They come out obviously in complete PPE, as you can see, and they sanitize with an aerosol inside of our ambulances. This is very effective for us, and while we can do surface cleaning with some different products, including alcohol, this process actually exceeds CDC guidelines and provides our members even a safer work atmosphere to be able to continue delivering customer service. The process does take a little bit of time. It takes about 45 minutes to complete the process from out of scene transport time from the hospital to get back to the station. Typically our crews, once they have an exposed patient or are exposed by a patient, excuse me, they will return to the station wearing their masks and PPE, drop their clothes, go in and shower, and one of the other crew members will go ahead and put PPE on, collect their clothes and throw it in the washer for them, and then decon 2 will respond. Over the first 30 days of the COVID pandemic, we called decon 2 approximately 89 times. In the last 30 days, we've had 247 decon calls to fire stations. Obviously, Phoenix is a large metropolitan city, so the geographic difference for the decon 2 to respond has been challenging. We've actually put it in a stationary position and had some of our ambos drive to that stationary position to get deconned. And we centralized that around a group of hospitals, which we were typically transporting many of these patients to. Just a couple other quick data points that I was sent. So in the city of Phoenix, in March, we saw 187 tagged COVID-19 patients. In the month of June is the last data point that I have because it's a full month. We saw 537 tagged COVID patients. And again, I could say that most of those patients are coming out of not only my station, but a couple of stations surrounding us. If you'll refer back to that all red slide that we have in the West Valley of Phoenix. So I will take your questions unless Dr. Gamer wants to chime in at any time to clarify or further elaborate on anything I've said.
Yeah, thank you. Thanks very much, Scott. Just a big wow in terms of like the rapid surge that you've had to respond to. And Garth, any comments before I have two quick questions?
No, the technical name of the decon agent, Scott, do you recall what that is? There's a question in the chat about that.
You got to go off the mute, Scott.
Sorry, I'm sure our folks from EMS could ask that real quick.
Okay, I'll get that information. Yeah, we had a massive surge. We had a couple of things happen right together. We had sort of a stuttering reopening of the state. to include Maricopa County from roughly May 5 to May 15th. And then, of course, the civil unrest came about, and we had kind of a peculiar set of circumstances in the Phoenix area. It was pretty hot at that time, not as hot as it usually is, but there was a lot of tear gas, pepper spray, those sorts of things used, and mask wearing wasn't as good here probably as other places where it wasn't so hot. And so all these were what we considered aerosol generating events. And I guess the combination of things makes it not real surprising that we sort of lead the nation at this point in a dubious category of spread of the coronavirus. One of the things that is probably eye-opening to most is that the positive PCR tests are anywhere between 11 to 20% given the day they are obtained. So that just kind of shows how prevalent this is in the general population. There's a phenomenon in areas that we don't have a problem with. It's the COVID fatigue syndrome or mask fatigue syndrome. People kind of let down their guards because of there's been a surge and now there's less of a surge. We didn't have that problem in Phoenix. So I'll get that information, and thanks for the opportunity to present. Great job, Scott.
Yeah, thanks, Scott. Great job. One quick question for Scott before I turn it over to our colleagues from Houston. Scott, so this, the description and numbers and so forth seems like this, the surge hit really hard, really quickly. From your perspective, like the captain's perspective, what was the biggest surprise and how did you adapt to that?
Biggest surprise. We were going on a lot of 911 calls, and we would see people with fevers, but their SATs were in the 90s. And then I think the biggest surprise for me is we would go on, I remember specifically early in the morning, is going on a patient and their SATs were 53. And we immediately started aggressive treatment on them, but 6 other members in the household were positive and they were all wearing masks. I would say the most taxing piece of this is the human side of it for us. I can tell you that we've had numerous calls where we've pulled sick people, diabetics, or immune deficient patients out of houses, and you have a wife and a husband. In my area, it's a very established community, very, very elderly. And they've probably married 30, 40, 50 years, and we're literally pulling them out with low SATs, and they have no chance to say goodbye. And the hospital policies are not to have any visitors here in Phoenix as well. So that's common in other places. But so you have a husband and wife that have been together, one of the other is the patient, and they really have no closure. We're basically ripping them out of their house with low SATs and ultra level consciousness. And that's pretty hard on our members. We're really struggling with some of that stuff on that side of it because we all relate to our parents or other family members in that situation. But as we work through that and struggle with it, I know we're trying to do the best we can. And I saw some other questions on the right-hand side about exposures. If one of us becomes exposed, obviously the department has an obligation organizationally to notify us. We're informally communicating with each other as far as who's exposed by who, when they got it, and what their symptoms are. And so we're doing a good job of protecting ourselves as well if we have somebody at our station that becomes positive. I really want to speak highly of our leadership and our union. We did have 2 stations that had significant exposures and positive tests. My shift, we had 3 people. Other shift had 5 people test positive. The leadership of the Phoenix Fire Department stepped in and basically put us all off to go get tested. They sanitized our station and our trucks. They brought in fresh crews and gave us a couple days off to get our test results. Like everywhere in the country, probably they're lagging far behind. 5 to 7 days later is when we got it, but the department really went out of its way to take care of us and make sure that we're protected and our families protected. On top of that, our union set up hotel rooms where if we have a member that is concerned about exposing their family, they can work through Local 493 and stay in a hotel room to self-quarantine and stay away from their family or their loved ones in case they have immune deficiency problems. So all of those things are significant for the membership, and really just huge kudos to the organization I work for to make sure everybody understands that they're taking us while we're trying to take care of our customers.
Thanks for bringing a very human side to this, which is extraordinary. So with that, I'm going to turn this over to our colleagues from Houston. And last week, Kevin and his colleague in their roles as in medical oversight presented. And much like we've done for Phoenix, we're going to do that for Houston too. Welcome, Senior Captain Sky Eagle and Captain Soto. Yeah, okay. You got the system. Raise hands. Perfect. Wonderful. So we've got your slides, and what we're going to do, if it's all right with you, go ahead and push them and just say next when you want to advance them. So with that, I'll introduce Senior Captain Isabel Sky Eagle, EMS Senior Supervisor, City of Houston Fire Department, and Captain Daniel Soto, EMS Sector Supervisor, City of Houston Fire Department. I don't know exactly, but I have a feeling about how busy you are, and deeply appreciate your willingness to take the time to share with people who can learn from your challenges and successes, just like Scott just did. So over to you.
No, thanks for having us. What we're going to do is I'm going to start with basically a brief overview of kind of our numbers from a distance, and then Senior Captain Sky Eagle is going to go more in depth into a lot of the efforts that our infectious control team has made.
Yeah, Daniel, if you get a little closer to the mic piece, I mean, this is sort of like the Zoom thing is hard enough, but then, you know, superimpose, like we got like the filters going on. Go for it. Thanks.
Is this better? Can you hear me?
Yeah, better. Thank you.
Okay, you can go to the next slide, please. I'd also like to just throw out that Houston's experience mirrors what they were saying in Phoenix very much. Everything from the decon task force to having to mask up at the station and the PPE concerns, it's very much what we're seeing in Houston as well. So starting off with these two graphs, what we have are our HFD members who tested positive for COVID in relationship to what we have deemed to be HFD non-compliance quarantines. So anytime we, based on the documentation or the interview with the member, if the proper PPE was not used, we call that a non-compliance quarantine. And so you can tell we have a big, what looks like a pretty significant spike in members testing positive for COVID. If you'll move to the next slide.
Can we hold there for a second? So are you able to go back to the previous slide really quick? Thank you. So this is Senior Captain Sky Eagle with the Houston Fire Department. So thank you very much for allowing us to speak. So good morning to all. And so as you're seeing those exact numbers and spikes, early on when we were first announced here in Houston, like in January 23rd, I want to say, of the first notification to us of COVID, it hadn't hit Houston yet. So as you see, the months are from March to July. So you don't see the January and February months, but in January was our first update or announcement for our medical direction of just giving us information of what COVID was, not yet going into a full effect of actions at that point. It was around February when we started taking some actions at that point. And so what was really, I thought was phenomenal on our medical direction side was that early on, we didn't have what we called a pandemic emergency response book for COVID. It was a lot of information being provided through our administration and through our medical direction, and of course, everything we were hearing out. So our medical direction did a really good job. He has a platform already, and where he provides information to the paramedics, to the EMTs, and he utilized this platform to basically bring all the information together, because a lot of the members were receiving a lot of information from all different directions. And so that was one real strong point that I believe brought all the information to one area to view. Originally, it was viewing information from CDC, Houston Emergency. And so by bringing this platform, since we didn't have an emergency response book at that time, it really assisted the members to go to one location instead of being very confused of different locations, what information is true, not true. So that was very helpful early on. And so then come March is where we actually started seeing all the actions being put into place as things were changing. And that's predominantly the first month where we really went into full actions was in March. And that's why you're seeing here the month of March, most of our, our actions and our graph showing that until July.
Yeah, so this timeline is going to be from about mid-March to end of June. So it kind of looks, the graph looks kind of scary. We've got just over 45 members who've tested positive for COVID, very few of those being due to non-compliance with our protocol. If we can go to the next slide. This will help put it in perspective. This is the number of COVID positive patients that HFD is interacting with during this time. So you can see it's pretty steady, at least from the mid-March timeline. And then you have this huge spike coinciding with our Texas reopening, basically. And the reason that we were able to, we think, keep our HFD members who tested positive, who have so far tested positive for COVID low, is in some small part due to the next slide, which was our aggressiveness with quarantining members. So the orange line is HFD members who have gone into quarantine. And again, this yellow line that you're seeing are the ones who've actually tested positive for COVID. Now, you notice this first spike kind of mid-March area where we're quarantining lots of HFD members without a correlating spike in positive COVID patients or anything like that. So where's that coming from? If you'll go to the next slide, please. It's around this time, mid-March, that we simplified our exposure form process, thanks to our medical directors. Instead of having to call in to a third party like workers' comp claim person every single time, it became this streamlined process where you could email or fax your paperwork to basically our risk management or infectious control personnel. And so you see members getting more comfortable taking care of their own exposure forms. Because before, like if you got exposed with a needle stick or hurt at a fire, a supervisor had to get involved, and it was kind of a process. You needed a lot of signatures. You had to call a third-party adjuster. You had to get reference numbers, and things had to be faxed back and forth. Making things simpler for the member and their immediate officer, you did see a spike as people were getting more comfortable with it, but it came in handy later because now when we have more COVID positive patients in June, they know the process, and you see this big orange spike, the members rolled with it in stride. Next slide, please. You also see a noticeable dip in members needing to be quarantined once the surgical mask worn by members at fire station protocol goes out. A lot of guys were griping about it. A lot of guys took issue with it as we saw kind of like this politicalization of wearing masks and social distancing, but we didn't really see another factor that corresponded with this dip in members needing to be quarantined. And then the third, next slide. You have Texas phase 1 and 2 reopening May 1st, May 18th. So right in there, and then this 14-day period after that, you start getting, and I'm sure the civil unrest in our downtown with the George Floyd protests may have had something to do with that too. But that's when we start seeing this big spike in COVID positive patients, basically with the reopening, just as I'm sure Phoenix experienced as well. The good thing is, from what we see, I think we were able to keep our members exposed to COVID down reasonably. Because you have to imagine not every firefighter, not every EMT is getting COVID just from a patient interaction. As Texas reopens and more family members and neighbors and friends are getting COVID, our members are getting exposed that way as well. So all things considered, we're reasonably happy with the little bump with the numbers that we have. So
some of the things that were implemented. So early on, we started to, the PPE was where everybody was wearing everything. So just imagine a ambulance, a medic, and an apparatus, the amount of people going to that location, putting on absolutely everything. So the fear was obviously there was shortage going on throughout everywhere, not just say, you know, in Houston at the time, in New York and other places. And so one of our biggest concerns was, where are we going to also encounter some of that shortage? And we were initially wearing absolutely everything for every call. And so then it became, how do we control this? How do we control where if we get to the point where there's a shortage, we started to use what we call the senior supervisors, as myself, to disseminate the replacement of the PPE. Well, imagine only 2 senior supervisors with a city this big, that many units, every time they made a call to try to replace it. So then we started using district chiefs to try to disseminate only to their area. And then we went into another phase, which was what we call the recon phase, which was a phase where when a unit arrives on scene, we were to use a recon process, which I thought was just phenomenal. And that happened like, I want to say around March, where how do we get a better handle of the usage of PPE and wear it appropriately at the incident? And so we based it off a situation more than just the suspect of whether the patient was positive to COVID or not. So it was what part, how close, it used this, what we call the 6-6. Where are you going to be in the 6-foot bubble of the patient? If you are, this is the minimal amount of PPE you're going to wear. If you're outside of the 6-foot bubble, then this is what you're going to wear. And obviously, if you are doing certain types of treatments and therapies, then you will wear up to including the gown, depending on the treatment and therapy. So that helped out a lot in reducing the amount of PPE that might have not been needed, overusage, basically. Sure, go ahead.
I was just going to say particular challenges. I was on FMLA from about March. I came back kind of mid-May when things were kind of sort of in a lull. And what I came back to was
let us show you if we can take.
So to catch up on all the COVID stuff I had missed, I don't know if y'all can see, it was basically about 250 pages worth of protocol changes and revisions. Our docs did a phenomenal job. Dr. Scholes and our head medical director, Dr. Purse, Dr. Souders, they were giving us video updates daily about COVID, what was coming out of the CDC, what was coming out of WHO, what practices we needed to be taking to protect ourselves, our members, the firefighters working beside us, under us. So extremely helpful. I think if we wanted to do another pandemic, at least from the fire department side, having a one-stop shopping center for all your COVID needs, something basic, something simple, something a firefighter comes back after his 4 or 5 days off. If there's been a big change, boom, he understands it, he or she understands it, and they can go out and help the public without getting bogged down with 40 pages of rescinded emails.
The other thing is we also had protocol changes as well, very similar, where if it was nebulized treatments were removed. Initially, we made 3 types of changes with that. It was initially if somebody needed a nebulized treatment, it was only if they met the certain criteria, low O2 sat and were in severity of respiratory distress. Then it got readjusted where only if it was approved by the medical direction. So we had some protocol changes also in our patient care reports. Initially, in our patient care report, it was requested that in the narrative they place COVID signs and symptoms that they encountered so that we could streamline and better address any kind of, needs to our members if they needed to be quarantined or whatnot. And so then that was very dependent on the person that was inputting the information. We realized that that wasn't working so well. So then it was more of a clicking, does this person have this, or this, and we would not, the PCR or the patient care report wouldn't be able to be closed out until those were clicked. And if you believe the patient was suspected of having COVID. So that helped, keep awareness of the numbers of types of, COVID patients and how do we help our members with that. That helped a lot. Also with dispatch system, early on, around February, we also went into where the initial call receiver or the call taker would ask some questions that pertained, did this patient could possibly have COVID signs and symptoms. Then we'd send an alert to our, what we call our MDT, which is our dispatch computer in our units, to alert them of what we call the IDA alert. And so if they, had that alert, they would view the notes and, be aware of that. Some worked great, some fell through, but majority worked very good. The other thing that we had is our infection control or occupational health department. So our infection control department was mainly used to dealing with just the needle sticks, the bodily fluids, the occasional body fluids that went into the mucous membranes, things like that, TB. But something this big, initially we did not have that, stand up in the manner that we have it now. As time went on and we noticed the need to upgrade and upscale this, we then no longer followed necessarily, like Captain Soto was saying, the normal process. We then formed tier groups, tier 1, 2, and 3. So like tier 1 was our initial call takers, and we needed to man that up with a lot of, 24-hour accessible to our members. So they always had a way to reach out to somebody in case of need of suspected COVID, of fear that they got exposed. So that had to be manned 24 hours. Initially, it was just the tier 1 and what we call the quarantine group. The group that, after evaluating the whole assessment of the triage of tier 1, did they require to be quarantined? And that group handled the entire quarantine process. And then we also, eventually we implemented the tier 2 group, which was also inclusive of the contact tracing. So there was the beginning, the middle, and the end, to try to tie and loop all this together and grab to be able to take care of our members, grab the appropriate data. And still today we have that process in place as we see this big uprise in this COVID. So that's where, those are the main things that if we had to look back and do it again, maybe put the infection control team all in a big group up and running early on as we started to see a spike and grow it as needed. Instead of we had never dealt with this. We hadn't had to make it this big and with that many tier groups and that much manpower within this infection control program. But I think at this point, it's what we have put into place in March for the second uprise. We're just utilizing the same actions that we had early on, and now we're just QAing those areas in case they need additional changes. And I hope that COVID doesn't throw us a twist where we're going to have to now come up with something else, some other different action. We also,
I'm sorry.
We also had the task force and the IM team also activated, as similar to Phoenix, where we had a decon team that would go and decon the fire stations, decon our units as needed, decon the city facilities that the firemen were utilizing in the office, in office, the wearing of the masks. So that, yeah, very similar to the way Phoenix was doing it.
Thanks very much, Captain Sky Eagle and Captain Soto. I mean, the rapid adaptations you've made and seeing those charts were quite impressive. Really appreciate your presentation and all the work that you're doing to save lives and help people in Houston. I want to go to the polling now. Last time, I put in some of the polling questions that we weren't able to get to last time. I had hoped that we would just be doing recovery questions, but that's not the case at this juncture in time. So we're going to be doing some polling to get the sort of like the state of where people are right now. So if Amanda and Amy, so for panelists and speakers who haven't been on before, we don't get to like respond. It really is helpful if everybody like goes away from their computers, except for like focusing on this and like providing responses. So from email over to these responses would be really helpful. We've got about 306 people on the platform right now. So let's see if we can get some responses. Today, which one of the following characterizes your EMS system in COVID-19? And for, I think, almost every one of these polling questions, there's a not applicable because you're like not in EMS, because we have a lot of people that aren't in EMS and on these rounds, just like critical care. We have a lot of people that aren't critical care on those rounds. So there's always something, so everybody gets a chance to like respond to these. All right, let's stop there. Preparing for a surge, 31%, responding to a surge, 30%, recovering, 14%. All right, thank you. Next. In your EMS system in the past 7 days, my access to adequate PPE while caring for patients is better, worse, the same. And then if you're not an EMS clinician or administrator, there's an option there too. This was pretty straightforward. So jump on your votes and we'll move on to the next one. And for the panelists and speakers, the plan will be after we finish with the polling, we'll go around the Hollywood Squares for each of the panelists and then to our speakers for their last word before we close. All right, let's show the responses, please. Better 8%, worse 2%, same 61%. Next. In your EMS system, which of the following PPE supplies are you most short of today? While people are responding to that, I should mention, and I do mention during each rounds, that the responses are seen by everyone here. You know, they're all here. These are also archived in recordings, so people get a chance to see it anytime they go on the website. And also, we share that here internally with the Healthcare Resilience Task Force or Working Group at HHS. There are representatives from multiple departments and agencies, including Department of Transportation's Office of EMS. Dr. Kramer sits on that, and other departments and agencies as well, such as FEMA. So I want to let you know, these are open for anyone, anytime to see. All right, stop. Number one response or highest frequency response is gowns. And then let's see, not short of any PPE, 22%, and then N95s. Next. By the way, cheering you folks on, there were 190 that voted on the last one. Really good responses. I mean, great. Is your EMS system using elastomeric reusable respirators? It's a simple yes, no, or not applicable. It might be too much to ask, but it would be great if we had 75% voted. We got like 59 now. John, I'm pushing the envelope here, I know. Pretty good. We're getting to diminishing returns, like 5 more seconds and we'll stop. Okay. 63% of you voted. That's awesome. 58% are not using elastomerics. Next. This one's also related to elastomerics, a little bit different. In your EMS system, if your access to N95 respirators is limited, would you consider using elastomeric reusable respirators? Captain Sky Eagle, I think you might be writing in your responses over there because you can't do the polling. All right, let's stop. 62% of you voted. Yes, 65%. No, 8%. Thank you. All right, next. We're moving from elastomerics to a new topic here. In your EMS system, in addition to COVID-19 activities, which of the following have you begun additional preparations for? Select all that apply, and you'll see like the threats: seasonal influenza, hurricane, wildfire, tornado, protests, other, don't know. Wow, we have 45% already voted. You know, earthquake, I just saw that, always earthquake. I got to tell you, I got to add that one in there. I added something in after I got like some input I forgot. I think I might have forgotten tornadoes before, so. Oh, I see heat waves too. Gosh. All right. And I actually, you know, everybody says during conferences, we really do change the conference based on your input. Well, I really do try to like add the questions I missed. All right, let's stop there. Okay, seasonal influenza, and it looks like protests are like the #1 responses, or highest frequency response. Interesting. All right, next. I know an EMS clinician who has been unable to work 1 or more shifts due to the mental health impact of the pandemic. All right, let's stop there. 66% of you voted. That's pretty extraordinary, actually. Yes, 33%. No, 51%. Don't know any EMS clinician, 16%. All right, thank you. Next. Improving your EMS agency's working relationship with which one of the following would make you much more prepared for a surge of COVID-19 patients? And I think you only get one response to this. Improving your EMS agency's working relationship with which one of the following would make you much more prepared for a surge of COVID-19 patients? I think there's 1 or 2 more questions, then we'll go to the panelists. All right, let's stop there. 65% of you voted, and looks like the highest frequency response, 26%, was public health department. And then the second most frequent is supply distribution chain. Third, emergency department. Thank you. Next. In your EMS system, which of the following strategies are being used for COVID-19 patient ventilatory support? Multiple choice. Yeah. Any of the ones that you're using, please select. I know it's multiple choice. It might take a little while to get to this one. All right, let's stop there. It's quite a wide distribution, with high flow nasal cannula being the highest frequency response, 38%, but quite a few others. All right. Thank you. Actually, for those of you who responded other, it'd be great to see in the chat what the other was. I don't know what the other would have, I'm missing that one. All right, next. iGel. All right. Which one of the following has been the most concerning in your organization's response to COVID-19? So it's one response. About 50% of you have voted so far. Thanks for responding in the chat about those other responses to the ventilatory support strategies. We'll close out in just like 5 more seconds. So if you haven't voted, all right, that's great. Stop there. The most frequent response, PPE access. That's pretty straightforward and clear. Adequate workforce, 20%. All right, thank you. Next. Which of the following, one of the following, has been the most helpful in your organization's response to COVID-19? Which has been the most helpful? For the panelists, given it's after the hour, we will go around, but if you could make your comments pretty like the take-home lesson, that would be great. All right, 5 more seconds. All right, let's stop there. Most helpful, PPE access, then it looks like more effective clinical operations. It's been gratifying to hear all the adaptations EMS systems have made throughout all the series that we've had on EMS. adequate workforce I see as well, for sure. All right, thank you. I think that might be it. So if the panelists can, yeah, that's it. Echo, if you, I think that's the end of the polling. Yes. All right, we can take that off, and we'll start with panelists. If you can unmute yourselves, panelists. We'll start with, hang on for a second. There we go. Doug, Dr. Kubas.
So just a quick question probably for Captain Crawley. I was curious about Decon Unit 2. Is that the only one for the city, or do you have several? And the other question is, what provider levels are doing the decon? And have you had any of them turn positive and get COVID infection?
I know that we had one decon unit that was responding early on. Our IMT is currently standing up a second one and at a geographical location. We were trying to actually get 5 of them and do a north, south, east, west, central Phoenix. In my opinion, just my opinion, I think maybe partnering with the hospitals to actually do the decon after we offload patients would be most beneficial and minimize out of service time for our ambulances. But I know our IMT is working very hard to get some stationary units up and running. The individuals that are doing it are also firefighters or paramedics. You could see that from that last slide. They're in full Tyvek suits and contained breathing apparatus. They have all undergone training on how to do that. There's a rotation cycle that they do. Those guys are also working on fire trucks. So to adequately answer your question about exposure from doing decon versus running calls, I don't think we could be able to differentiate correctly on that one. I know that those guys are working hard. I mean, it was 116 degrees here yesterday. So to be in those suits and running that, those Tyvek suits for hours, 16, 17 times a day for those units, those guys are putting in a lot of work. So we really, truly do appreciate all their work and the support that we've had from leadership on getting us more decon units and the resources to do decon. We also do contract with some local vendors here as part of our IMT to do our stations and to do some of our public City of Phoenix buildings. So that's just an added caveat.
Dr. Kramer, I was going to you next anyway. Yeah, go for it.
Thank you, Rick. And I'll ask just a quick follow-up, because both of you operate in an environmentally very hot environment on a routine basis. And now you've got PPE issues to address on top of that. Have you implemented any other workforce safety issues or whatever in relationship to hot environment PPE?
So because we're running regular fire calls and everything else, our physical conditioning, we've minimized some of that because of the temperature. But as far as PPE goes, if we need somebody to rotate, we'll rotate. Wearing masks and gloves and gowns on the calls that we are, we normally have a chance to rehab after that, whether it's the air conditioning. Here in Phoenix, everything has air conditioning except for the outside atmosphere. So it's good for us to be able to cool down after that. But we try to minimize the exposure. Like I said before, I think before the chat started, sometimes in these care facilities, we're sending in the ambulance crew and just one of the crew members, or bringing the patients outside of their own homes to minimize that exposure to our crew members. Because, here in Phoenix, if you have one member positive, you have 3 or 4 members positive in the house. And we just try to minimize the exposure that way. So it's just a continued effort on social distancing and wearing PPE. Fortunately, we've had great support from our IMT, and the state and our fire chiefs work very hard to maintain our PPE levels so we don't fall behind. And I know that they're also working on a program here with FEMA as well about cleaning some of the N95 masks.
John, anything further? You good? Okay, great. Dr. Tan.
Just another great clinical rounds. I thank Houston and Phoenix so much. A lot of great take-home messages, and in the interest of time, the one I would pick would be that the message continues to be fairly consistent that PPE does work, and that perhaps the EMS personnel's greatest risk is not so much from the patients, but from each other and from being out in public, as it seems like the public is a little bit less diligent about PPE usage sometimes. And so again, probably one of our biggest challenges will be this long-term marathon of maintaining that PPE diligence while on duty and off, and at the station, whether it's the firehouse or the ambulance station.
Yeah, thanks. Thanks, David. And the whole complacency fatigue thing, and then we talk with our colleagues in Houston and Phoenix, and wow, yeah. Rob.
Hi, thank you. Thank you to both departments. You guys made excellent presentations, and I agree with Dr. Tan about the PPE comment. I just had a question, and maybe the medical directors might want to jump in, but are either of your departments considering doing any antibody testing in the near future for your members?
So I can answer for, we actually, 493 did some antibody testing in early April. We partnered with Vincere Cancer Institute here in Arizona, and we were able to get private sponsors, Blue Cross Blue Shield and the Phoenix Suns charities, to cover all the costs. We have six cities within our local, and we tested about 2,500 firefighters, and our results were less than around 1%. We also worked with our police partners as well, because we have a great relationship with them, and their results were about the 1% as well, and they have just roughly over 3,500 individuals. So we have done antibody testing. We continue to work through the current testing issues that we have, and I know that the 493 leadership and the fire chief for Phoenix have been in contact with Vincere, as well as looking at maybe doing some further antibody testing in the fall once we get through this big wave or this big heap for our members.
I want to make sure, Houston, anything on the antibody piece or question?
So we talked about it on our end, and we opted at the time to not go with it, just based on the concern, the number of questions involved in, what does it truly mean? What level imparts immunity? Do you get immunity? How long does it last? Et cetera, et cetera. So at the moment, with 3,500 members on the Houston Fire Department side, and we did talk with the police department, which is over 5,000 on HPD, we decided at this point it wasn't, some people are doing it on their own, but we decided not to do it kind of across the board.
Just to echo what Dr. Schultz had to say, is so early on in the pandemic, the results were, I expected much higher antibody positive results, but I think that the 1% that Captain Crowley talks of was maybe foreboding of how badly the surge came to Arizona. We would have expected more positives earlier on, perhaps, but the lack of positives probably left the whole population open for viral seeding once we have reopening procedures and the civil unrest.
Thanks, Garth. Dan, and then there's the square that's got Phoenix Fire EMS that doesn't have any people on it right now. The video's not on, but I'm going to give you a chance after. Oh, there you are. Okay, after Dan. Dan.
Just a quick question for Houston Fire. Your quarantine of employees, do you have a protocol that you follow, and where did that come from? Did that come from occupational med, or did that come from your medical director?
Definitely do have the set criteria of what level of quarantine they are to, if it's just a low risk self-monitor for 14 days or medium to high risk criteria, do they fit into that criteria? And that puts them off to be quarantined, depending if they were exposed to a coworker or a family member of the community, or are they actually feeling signs and symptoms? They're all a little different. And that was developed from our medical direction, along with the usage of the CDC information. We're blessed here in Houston that our medical director is the health department authority as well. So that just was astronomically helpful in our department, which also made our members feel very trustworthy and secure of these protocols that were being put in place because of our medical director that we have.
Great, thank you.
Thanks. Yeah, and okay, so Phoenix Fire EMS, any comments for the good of the group before we close out with our speakers?
No, just thanks for having us. I know this is unprecedented time, and we've said that many times, and it's probably going to change in the future also. So hopefully we can do this again, just so we can kind of keep up with the changing times, and it definitely helps us our training and getting this information out to the members. So thanks for having us.
Joaquin and Roy, I couldn't hear that. I doubt if anybody else did.
Thank you. How about that? Thank you. Sorry, I think we're having a little technical difficulty.
Yeah, it's the whole internet thing it's never seems to be perfect, but then you superimpose masks on it, and it's sort of like a masking technique for the internet, and I don't know what to say. So thanks for being here, okay? I mean, you're working really hard, and you're being here sharing with others, so thank you for being here. Kevin and Garth, any last comment before I turn it over to your captains?
Well, I don't really have anything else to say that what I've said the last week or two. I think reopening was good in some places, other places premature, and we're reaping the harvest from early reopenings in certain places. I think that I've been trying to keep up with answering questions in the questions area, and I appreciate all those questions and concerns. There's one thing I saw about proning, and with short transport times, we haven't really gotten into that. Position of comfort, kind of a rotisserie concept, rotating patients from one side to the other, recruiting more lung tissue at various points during the transport is probably makes the most sense for short transport times. And then one last thing, I think all municipal EMS agencies need to gear up their mass immunization efforts, and that's for a number of reasons. COVID, obviously, if a successful vaccine comes out, but also for seasonal flu, this new G4 H1N1 thing that's brewing over in China, and then the childhood immunizations that are being neglected because of concerns about taking people into doctor's offices and such. It all equates to one thing for me, is that frontline providers in EMS will be doing a lot of immunizations.
Thanks, Kevin.
So very briefly, I just want to say that the biggest take home for me was the ramp up of the infection control process. Most of us have infection control processes that are, as Captain Skygill mentioned, set up for the occasional needle stick, the occasional bloodborne exposure, whatever it may be, and to take it from, and we pretty much had one person with some kind of temp help doing it when we started, and myself and Dr. Souders, we spoke last week, jumped in to help early on, but now, and our department has utilized field supervisors like Captain Soto and Senior Captain Skygill. In fact, when I stepped out earlier to look for them, I wandered into the room where the people are working, and there are about 5 of them up here right now working the phones and doing record follow-ups and that kind of stuff. And that involvement of field personnel, supervisory personnel that the field already knows, it was the best way to ramp that up, where they were already trusted and involved. So I think that was a really well put together piece on our command staff side, was to use those personnel to bring up the level of our infection control.
Thanks, Kevin. So I want to go to Houston. And it's one question. So one question as your final answer. So there are a lot of people on these rounds who have never, ever seen a COVID patient. And you saw in the polls, the percentage that are still preparing. So what's the most important thing you could tell them that will help them when they see their first or they see their surge of COVID patients? You can have the same answer or you can have different answers. There's two of you. It's okay.
It's going to be nerve-wracking. I know coming off of FMLA, having a newborn son, going out into the field, encountering COVID patients kind of felt like going through a minefield. But the patient is just as concerned, if not more scared than you are. COVID is scary. COVID is something they see on the news, and COVID is something that they didn't think would happen to them. And it affects everyone. So keep that in mind, that while you're dealing with your own system, your own way to process it, that what you have is a patient with, to them, an unknown disease process. And that's gonna take extra steps to de-escalate their worry.
Thanks, Captain. Captain Sky Eagle.
Yes, definitely agree with what Captain Soto said. I think also is to entrust in the actions that you have in place to, like Dr. Schultz said, the infection control person, that whole group, have it in place early on, and and grow it as you're receiving the growth of the virus or the pandemic. So yeah, definitely. I also, PPE, definitely entrust in the PPE, entrust in the protocols that you have in place is, to me, very important. If the members are not adhering to it, when they're encountering their first case, there are multiple cases, that is where, I believe that's where you have the problems, maybe of the exposures and the quarantines and the increase of the quarantines possibly.
Thank you.
Dr. Hunt?
Yeah, please.
Oh, yeah, I'd like to tap onto that, the response. Because there was a lot of misinformation, I think for us, a lot of it, we were learning it, our trial and error, on almost not on the fly, but we didn't have resources to go, hey, this department did this before. So it would be nice to have a lot of these departments push out what worked and what didn't work. For these departments that haven't had a lot of exposure or had these high numbers of cases, it would be nice for them to go to a resource that they can go, okay, this worked and this didn't work. And also when they do that, that trial and error, it would be nice to test their system within that before they actually implement, those procedures. So just something to tap onto.
Yeah, thank you. No, and while you kind of like did the essence of the purpose of these rounds, that's insufficient alone. So points well taken. Yeah. So I've been wanting to say this since the very beginning of rounds. Captain Scott.
Yes, sir.
Yeah, so the question, like, you're the final word here. All those people that haven't seen a COVID patients or haven't hit the surge yet, what's the one thing you would tell them that they need to know?
I think as EMS providers, we see people with SATs in the low 90s or in the high 80s, and we start to aggressively treat them with oxygen. And unfortunately, we're looking at patients in the low 70s before we're escalating our treatment or transporting those patients. So a really hard look at triage protocols or triaging patients when we respond as 911 providers on who needs to go to the hospital and who could really stay at home and continue to take the Tylenol and hydrate and those kind of things before we overwhelm our emergency rooms. I think the only other thing is for everyone out there, when you start to see the uptick, your members will get frustrated. They'll get frustrated because they want to get tested. They can't get tested. They can't get the results back fast enough. We're used to 911. Somebody calls 911 and we make decisions in less than 5 minutes and fix problems. When we're at the mercy of tests that take 7 to 10 days, it's extremely frustrating and causes a lot of angst for our members. And that transforms back into their home life as well, where they have a lot of family members or spouses that are concerned, or their kids or their families. So keep the perspective that everyone's frustrated and we're all doing the best we can. And for those of you that are leaders in the fire service or medical directors, keep checking on your people. I can't say enough good things about the organization I work for, that is really a member-centric organization and provides us opportunity for, you know, leave or a place to stay during self-quarantine if we feel we had a significant exposure. And that mental health side of it for us, or for myself, I think goes a long way to calm the frustration, or at least know that everyone's doing their part in leadership and as our medical directors. So that's how I close. Thank you all for the opportunity. Dr. Gamer, thank you for the opportunity. And it's really wonderful to hear that you guys are doing this on a weekly basis, and keep working hard for those agencies that haven't seen an uptick yet, because it seems like it's gonna make its way around to everyone sooner than later.
Thanks, Scott. We're going to close this out. Dr. Strominger, anything before we close?
Just thank you. Super productive discussion. Thanks, Scott and Daniel and Isabel and all our panelists. And it was a particularly active chat comments and Q&A comments. The participants were very vocal today. So thanks to everyone, and for many people stayed over 30 minutes to keep the conversation going. So be well.
Yeah.
Have a good week.
So Bruce, I got to figure out how to keep this down to an hour, but I actually think about, when I reflect about these rounds, this one, I would encourage anybody in EMS to go to the archive and look at the recording. This has been an invaluable session, which is why I just let it go, because yeah. So to the participants, wow, not just hanging in there till the hour and a half, but also the participation in the chat and the polling. I mean, it's extraordinary information that you've shared. For our panelists, and in particular, hey, thanks Kevin and Garth for helping recruit our colleagues that reflect the boots on the ground, as it were. That I think has been really invaluable to all of us in sharing. Really appreciate it. To our other panelists, thank you for being here as always. You always show up. Great comments, expostulations, wisdom, and to our colleagues, Captain Soto, Captain Sky Eagle, and Captain Crowley, you be safe out there, okay? And really, really appreciate how hard you're working. And I know my emails to you, you don't have time for this, and I get this, but what you're sharing amplifies what you've learned to many people who really do need this. So thanks so much all, and we'll see you on the next one.